Spectrum TV, broadening your horizon.
All right, welcome to today's episode of the program Inside Motherhood here on Spectrum Television. This is a program that talks everything you need to know about motherhood. Well, today isn't anything different, as we are going to talk about what concerns the mothers. Yes, if you are a mother, an intending mother, of course, as long as you are a woman, a lady, and even the men as well, draw closer to your TV sets. We're about to talk something very, very important. And of course, we have a guest in the house, a resource person that knows better in the field, that will be talking to us as we talk about cesarean section, anything and everything you need to know about cesarean section. Of course, the meaning as well. We're going to find out on today's program. My name is Rachel David White. All right, so I'll start by opening the phone lines so you can be a part of the conversation. But first, you've got to listen to us, whatever we're going to talk about. So if you have questions, feel free to call us. You have contributions, feel free to call us. It's highly educative and informative. All right, so in the house, I'm being joined live by Dr. Ekomobon Udo. Welcome, Doctor.
Thank you, Rachel.
Okay.
Good afternoon, viewers.
All right, so Doctor, a quick one. Let's just get to the business of the day. I apologize for starting behind scheduled time. Well, we're talking about C-section, cesarean section, CS. The short forms doctors give to the whole process. So many persons do not even know what it means, but they hear CS. So let's start there.
Okay.
For the benefit of people that are listening that may not know what it means.
All right. Thank you very much for the question.
All right.
All right. Cesarean section, popularly known as CS, is a surgical procedure that is carried out on pregnant women, carried out per abdomen in order to get to the uterus and deliver the baby. Okay. So instead of the normal vaginal delivery, a surgery is carried out, which they call the cesarean section, whereby incision is made on the abdomen, deep down into the uterus,
wow. Okay.
And then the baby is delivered.
Okay, so let me ask, how many layers? It sounds like you have to go to the last part. So how many layers do you need to go to get to that point? Okay.
You have the skin, the subcutaneous layer, then we have the rectus sheaths, and then that's a tough, fibrous, sheet that protects abdominal content from coming out.
Okay.
And then the muzzle, and then before you get to the peritoneal cavity, and then the uterus.
Wow, that's a whole long process actually. For the sake of how it's gonna look like, I would have loved to put it out on the screen, but let's just talk about it. Okay, so we've talked about that, but is cesarean section a major surgery?
Yes, in every sense of it is a major surgery.
Okay.
Yes,
and then does it have any types? It's just
cesarean section. We have the lower segment cesarean section, then we have the classical cesarean section. Okay. Just depending on the location, that's where the different types come in. The lower segment, the common one that has been done, the lower segment, where the incision on the uterus is on the lower part of the uterus. And then the classical is on the upper part of the uterus, high up, and then is a longitudinal incision, unlike the lower segment, which is a transverse incision.
Okay, now there are two types, right?
Yeah.
Now what leads to the other one, the longitudinal, and of course the abdominal? What leads to?
Okay. There are different indications whereby you want to go for the classical. Well, like I said, the one that is commonly done is the lower segment cesarean. So where is it?
And that's
the incision?
The one I know.
So the incision is on the lower segment transversely to deliver the uterus. But in cases whereby you cannot access the lower segments due to probably huge fibroids that is obliterating, or maybe some other forms of difficulty, maybe a very difficult surgery, you want to go eye up to get the incision and bring out the baby.
Okay.
But that comes with the complications as well, so people don't usually try that post times.
So nothing to hide. We need to talk about the complications, but we'll get there.
Back there. Yeah.
So before then, what actually, you know, leads to cesarean section? Now, I know that there are so many people that want to put to birth and they're like, I don't want to go through the, you know, labor pains, so I just opt for cesarean section. So, but what leads to, aside from the fact that you willingly opt for it, okay? I've seen situations where doctor comes out and says, oh, you can't push. At this point, CS is the only option, and we see lots of tears come out from that. Okay, so let's get to that point. What leads to it?
Okay, basically, there must be a clear indication for a cesarean section, a clear medical or obstetric indication for cesarean section.
Okay, now I'm sorry to cut you. Now, apart from the clear indication, what happens to those ones that naturally opt for it?
Yeah, that's because that's because in our climes we've tend to adopted that, oh, I don't want cesarean section, I don't want to deliver vaginally, I have to. That's where we put the term maternal requests. There is a cesarean section on maternal request, but in the sense of it, in obstetric practice, it's usually downplayed. But you cannot refuse a woman that doesn't want to pass through, go through vaginal births, and you cannot refuse her the option of having a cesarean section. But basically, when we want to carry out a cesarean section, we do that following obstetric indications.
Okay, now let's talk about the obstetric indications, and of course the clear. What did you talk about the other time? Okay, so let's get to that point now. Okay,
the obstetric indications, we want to divide into the ones that are relative and the ones that are absolutes. The absolutes meaning that under no circumstances should you try vaginal births in those persons, and then so those are the absolutes. Why the relative is that yes, you may want to try, but most times people don't try. But it's not that if you try vaginal births you may not achieve, you would. But so that is why it's called relative. So let's just start naming them one by one. We have a case whereby this woman obviously has an inadequate contracted pelvis, what we call contracted pelvis, mostly found in women with short status, those that have had previous pelvic surgeries before, have fractured their pelvis, that tend to make the pelvis to be contracted, not to be well capacious for the baby to pass through. Those ones fall under the absolute. And then for a woman that has had 2-3 previous cesarean sections, you want to obviously go for the next cesarean section. You will not want to try vaginal births in these our climes, although in our other developed climes they want to, with close monitoring, they might want to still go ahead with that. And then if in conditions where we have placenta previa, a major type placenta previa, whereby the placenta has occupied the lower segments of has occupied the external, that is a cervical os, where the dilatation to take place for the baby to come out. The placenta has covered it, so there's no way that baby can be born vaginally. That's another absolute indication for the cesarean section. And then for women that have advanced cervical cancer of the cervix, you also want to opt for a cesarean section. For cases of cephalopelvic disproportion, whereby the baby is obviously bigger than the passage, which is a pelvis, that's another indication for cesarean section. Then in labor, if the labor obviously is not progressing the way it should progress, spending a long time laboring, and you find out that obviously there's no descent, that is, the baby is not making descent down and it's not getting distressed, you have to make sure that baby comes out, and that's when we also opt for a cesarean section.
Okay, now I've heard babies in distress, babies in distress. At what is this distress? At what point would you say the baby's in distress? Yeah, to us, okay, we don't see, so you know, we don't understand what it means by the baby's in distress.
Okay. There are clinical parameters and also biochemical parameters we use to assess babies in distress. The clinical parameters, one of which we use is the fetal heart rate.
Okay.
The baby's heart rate in utero, and it has a range, and whereby the fetal heart rate starts going extremely high or gradually starts going down. We tend to, because it starts, the distress starts by having a very high fetal heart rate, and then after a while, that high fetal heart rate is the baby's body mechanism trying to cope with the stress. And then if it's not picked up on time and it's allowed to prolong, it now gradually becomes, the heart rate becomes low, and then that's one ultimately may lead to the baby's demise.
Oh, wow.
Yeah.
Okay, let's get to the whole process now. Maybe not in details, but just an you know, a summary of the process.
Okay, of the process in carrying out the cesarean section, right? Like I said, you have to have an indication for the cesarean section, and properly explain or counsel the patient in details on what the procedure entails. It's a surgical procedure, and like every surgical procedure, a major surgery for that matter, it comes with its own complications, its risk and complications associated. So you have to explain this to the patient, explaining the risk of the surgery, the complications that may arise, and also how you try to avert those complications going forward. After that, she has to sign a consent form indicating that she has listened to you, and she also
just in case she dies.
No, it's for medical legal reasons, kind of, that she has listened to you, she understood what you've told her, and she's willing to go ahead with the cesarean section. And then we have the preoperative procedure, whereby we have to take blood samples for some investigations, estimate our hematocrits at blood level, get blood group and cross match, do the urinalysis to make sure that she's fine, and then the anesthetist has to review her, making sure that she's fit for the surgery. The theater will be booked, and then she'll be prepped, cleaned, shaved, catheter will be passed, and then she'll be wheeled to the theater.
Okay, what's the essence of the catheter?
Okay, it's to relieve the you don't want to go in with a full bladder, because the bladder is just anterior to the uterus, and so you have to relieve the urine so that you don't inadvertently, because it's also one of the complications of the surgery, you might have an inadvertent injury to the bladder while going in. So it's part of the procedural preventive measures to actually relieve the pressure by passing and retaining a ureter catheter, to also help to monitor urine outputs also during the surgery as well, to make sure that she's making adequate urine because of the anesthetic agents that will be given to her during surgery as well.
Okay, this is just a quick one to remind anybody joining us right now that we are on the program Inside Motherhood here on Spectrum Television, and we are talking about cesarean section, C-section, CS, whatever you like to call it, the process where a woman puts to birth rather, through operation, surgical operation. And we have in the house Dr. Ekomobong Odo, who is here to tell us everything we need to know about it. What questions do you have? What contributions do you have? Feel free. The phone lines are open so you can be part of the conversation. All right, so coming back to you, doctor.
Okay.
Now, let's get to the side effects, the risk associated with CS. Now, I'm asking this because we have a situation where, okay, I wherever I talk, I like to use myself as an example.
Okay.
I've had 3.
All right.
Yeah.
That's lovely.
So, I've had a situation where I need to talk a pregnant woman, a woman in labor, into agreeing to have CS. Now, that's because of the fear associated with cesarean section, you know, you hear things like, okay,
Those
I've
are
heard.
like myths, actually. They're not actually true. They are just myths.
Oh, really? No,
Yeah.
I am. When I was about having my second baby, um, immediately the doctor examined me in your hospital.
Okay.
Yeah, during antenatal, he already told me from day one I was gonna have, you know, go through another cesarean section, and then the first time he said it, he said because that's compulsory, I can't try a normal vaginal birth.
Birth.
Yes, so okay, I think the way he said it was quite scary. Yeah, but it took another person to explain better. Now, there's this fear, okay, and then we also hear things like, what if the nurses overdose on you, or what if you know, light goes off in the theater, you know, a
I
whole
understand
lot
those
of
fears.
yeah, and then you know the whole process. So you need to talk a pregnant woman who is in labor into agreeing to, you know, go through the process. So people think it's a death sentence. Now, we still have situation in our world today where you see a husband refuse to sign, you know, just for the woman to be operated because he's scared. And we still have things like, oh, my church do not allow this. We still have things like, oh, the woman is not a woman enough to be able to
Yeah,
push.
that's a major one I have been hearing
Okay, so
severally.
but we'll get down to that part. But now let's talk about the risk associated with that before we get to this part. And then okay, let's just start there first.
Okay, like I pointed out earlier, it's a surgical procedure, a major surgery, that is not without risk, its own risk and complications.
Okay.
Now, one of the complications is that while during surgery, they may be bleeding. They are cutting through the skin, like I said, various layers before you get down to the uterus, and also cut through the uterus to bring out the baby. They may be bleeding, and they may be what we call massive hemorrhage. And when is that massive, it might lead into hypovolemic shock, and subsequently might be
Please do well to just
okay.
after calling the terms, explain it.
No, you know, a shock whereby the person goes into shock. The blood pressure is so
Okay.
the blood pressure is so reduced because of low blood in the
Okay,
body
yeah.
because of the blood loss, and that will now deprive major organs of blood supply, and
Okay.
it's also going to tilt that person into shock. Yeah, and then we also have cases of inadvertent injury to structures around the uterus, structures like the bladder, the uretras, and also even the bowel, because when you're delivering the bowel, most times you see the bowel out there, and so if you're not careful enough, you might also injure
What's
the
the
bowel.
ball? Yeah,
The
yeah, you know
intestine, the
oh, okay,
intestines.
okay.
That's why I use the
Yeah,
bowel.
I know it's called ball. I've
Okay,
heard that a lot.
okay.
Okay, so those are the only risks we have.
Yeah, then yeah, there's also risk of infection.
Okay.
So these patients must be adequately prepared, given intraoperative antibiotics, and even after the surgery, also be covered with antibiotics because of the risk that's of infection, most probably infection of the uterus, if not
Oh, okay.
properly managed.
I think
But those
okay.
risks are in a well planned, supervised,
Okay.
and properly carried out cesarean section. Those risks are usually very, 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 very minimal. Very
Okay.
minimal.
Okay, but I've seen a situation where infection was caused via the catheter because it was not properly handled, you know, properly kept in
Okay.
a decent place. So, do we have cases like that?
No, ideally after cesarean section, if everything being equal, the catheter shouldn't be there for more than 24 hours. Some cases they say 12 hours.
Oh, really?
So except in cases whereby there was an obstruction during the labor process and you want to rest the bladder for a long while to avoid complications of leakages of urine into the vagina, that's where you keep it for long. So because we don't keep it that long because of the risk of infection, being a foreign object in the patient's urinary tract. It can also evoke infection as well. Yeah.
All right. So let's talk about the anesthesia now. We have a process where the person totally passes out, and we'll have the other one, the spinal.
Okay.
Yeah, you'd like to give it a name and explain better.
Okay. We have the subarachnoid block. That's the spinal. You commonly call it the spinal anesthesia. And then we have the one where we give the general anesthesia. That is the person is completely unconscious. We take over the respiration, and she's not aware of her surrounding. Unlike the spinal, where just a little injection through the spine to the subarachnoid space that numbs the area from the lower part of the body down to the leg, so she doesn't feel anything throughout the surgery till the surgery is over. Only after some few hours after she recovers. And so both times except in dire emergencies where we have to quickly intervene, that's when we usually carry out the general anesthesia. The spinal is what we use most times.
Okay.
Yeah, the spinal anesthesia.
Okay, but which one do you say is safer?
Like I said, they have their own indications, and they have their own risk associated with it. But basically, the spinal also is what we do, because the spinal.
Let's just take a call. Come back to that. Hello, good afternoon, and welcome to the show. All right, so we'll hope that the person is going to call us back. All right, so if you're just joining us, this is the program Inside Motherhood, and we're talking about cesarean section. I expect a whole lot of questions for Dr. Ekomabong here. Of course, he's ready to attend to all your questions and reactions today. Okay, so we've talked about the side effects. We've talked about the anesthesia, the different types. And now the question I want to ask is, how long does it take before the bandage is off and the healing process? And also, you know, how long does it take before the person gets up, you know, is able to get up and maybe starts walking and the rest?
All right, most times that is usually the fear of women, but it's in practice, post cesarean section, minimum 4 days, you should be discharged home.
Really? So at what day is the bandage off?
Yeah, most times by day 3 we inspect the wound to see if it's okay, if it's clean, dried, well apposed, and then you notice that there's no obvious discharge. And then if the patient's blood level is okay, optimal, post-operatively, you can discharge the patient on prescribed drugs.
Okay. Now, how long before the wound now, like the whole process, the woman's body is back to normal?
First of all, after surgery, ambulation within 24 hours, at least the patient should be up and doing it. Ambulation also helps in quick recovery. So we usually encourage early ambulation.
What's ambulation?
Trying getting up, sitting out of bed, moving around, maybe going to the toilet. And that is one reason why we don't keep the catheter for more than 24 hours. So that process whereby you want to go to ease yourself, it also helps you moving around and aids quick recovery. And for the healing, usually by the fourth day when you want to discharge this patient, you find out that the wound is well apposed, you clean it, and she's discharged. Okay,
now that's not the healing I'm talking about, but let's go back a little before we come to the normal.
I know the healing you're trying
to. Just a minute. Okay, so we hear don't take water. Have you gassed? You know, what meal do you start with after cesarean section? Let's just, you know.
You're really talking out of experience, actually. Yeah, it's true. We don't encourage anything via that is oral intake, at least till we are able to ascertain that the bowel sounds have returned. The bowel sounds is the intestines, there's flow of gas or fluid down.
Why is that?
Because we don't want to cause what they call I don't know if I'll bombard you people with
No,
grammar,
no,
but
of course, as long as you're here
there's
to
there's
explain the
what we
grammar.
call paralytic failures, whereby the intestine just stop, then they don't there's no activity.
Okay.
And so when you take things down there, when the condition is there, that person tends to have distended abdomen, what we call obstruction, because things no longer flow
Yeah.
through the passage where it should flow, and then they just accumulate and cause that distension. So we don't want to allow that. That's why we usually ascertain that the bowel sounds are not just there, they are normal active. That is, you can hear that the sounds are very okay before you allow that. And then what was your question again? When she starts taking oral sips, you don't just load the person immediately with this strong solid food like that. You tend to slowly return the bowel activities. That's why we start with oral intake, warm coffee or tea, Lipton tea, and then gradually we move to pap.
Yeah.
And then after pap, we now say, okay, soft
rice.
rice, and then afterwards, soft rice, fruits, vegetables, and then afterwards, gradually you start introducing the normal adult foods that you usually take.
Okay. All right. So let's get to the healing process now. But this is just to remind the people that the phone lines are on the screen so you can be part of the conversation. Now, there's a whole lot to talk about on this topic, but we just have limited time. So let's just touch the points that we need to. Let's get to the healing process now. How long does it really take? Like, can you boldly say, oh, I had CS last year or 4 months ago and I'm fit for everything right now?
Okay, that's the healing you were trying to talk about. Okay, usually we advise that at least 6 months minimum before you try to attempt getting pregnant again. But the interpregnancy interval should be, most times we say 1 year. There should be an interval of 1 year before pregnancy is achieved.
That now makes me ask, a woman who is pregnant, right? Okay, who has had CS for 3 times?
Yeah.
Can you say you just give spaces of 1 year each?
No, that 1 year, one minimum of 1 year before you attempt getting, yes. So that by the time you're about going into labor, that should be more than going to maybe 18 months, and then you're sure that yes, the integrity of the scar on the uterus is optimal. But although there are circumstances whereby the integrity can be in doubt, obviously if there was obvious infection going into this surgery, there was obvious infection even post-operatively, if there was obvious infection, wound dehiscence and surgical site infection, those actually make the integrity of that the uterus not to be as strong as it should be, and so we will not want to we want to give a longer time for those kind of cases. Or next time when they come, we will not want to try labor because the fear of the wound giving way actually might be there, so it's usually complicated.
Okay, sometimes you hear things like the uterus ruptured.
Okay.
Now that's so you try to find out. Say the person has had cesarean section and the thickness of the scar was quite thin.
Yeah.
So could you explain better?
Yes. Uterine rupture is commonly for women that have delivered before, and probably and more commonly among those that have had a cesarean section before, and probably they go into labor when with a very short interpregnancy interval, or in cases where the integrity of the uterine scar is not fully what I call it, healed. It hasn't fully healed. So when labor starts like that, and if not properly monitored, the contractions continues because the baby has to be expelled, and with that contractions, since the integrity of the scar was not firm enough, it gives way and opens up, extruding the baby out of the uterus, and most times the babies, the fetus, they don't survive.
Wow. Okay. Now let's get to this point where how long does it take for a woman who has had cesarean section to have sex? Like, you're healed, you're ready for sex.
That's a very controversial question, actually. Yeah, we usually say at least um, minimum 3 to 6 months.
Okay.
Yeah, yeah, yeah. At least allow for enough wound healing to take place.
All right.
Yeah.
Okay, so now we've talked about that. You've talked about how long it takes for that woman to, have another child, right? Okay. Usually, um, I hear things like women who go through CS do not need to tie their tummy, they don't need to birth the hot bath, in order not to upset the womb. Just let's talk about that a little.
No, you have to keep the surgical site clean and dry at all times, because a wet a wet environment is a milieu for bacterial growth and infection to take place. So most times we advise that it should be kept clean and dry. On use of what they call it, to press the abdomen, you will not advise that, because while trying to do that, there could be an inadvertent injury, not even if it's not to the uterus itself, but to the skin, the skin incision and all that. They could also be opening of the incision site and lead to wound site, surgical site infection, and even wound breakdown also.
Okay.
Yeah, so we don't usually advise that.
Okay, but can a woman who has gone through CS, try normal vaginal birth?
Yeah, it is what we call vaginal birth after cesarean section.
Okay.
If she meets the criteria,
What are the criteria?
if she meets the criteria, yes, we can allow her to try vaginal birth after cesarean section. Some of the criteria include, like I said, the interpregnancy interval should be at least 15 to 18 months. The reason for the previous cesarean section should be a non-reoccurring one. And then we also want to ascertain that the birth weight of the previous baby and the birth weight of the current baby. We also want to ascertain if this baby coming cephalic or lying having a malposition. And then we also want to take into consideration the integrity of the scar itself. Like I said, was there post-operatively, was there an infective process that compromised the integrity of the uterine scar? Those are what you take into consideration. And then yeah, just to mention but a few.
Okay. This one sounds like it's not important, but of course it is. What are those things that you would advise if you've gone through CS? Do not do this, or even if you have to do this, let it take this particular, specific, time or month.
Basically, if you've gone through cesarean section, we advise for the interpregnancy interval. We advise at least you give yourself time to recuperate.
Aside from the interpregnancy, interval, I'm talking about normal chores in the house. Okay, we hear things like, "Oh, don't carry that."
Okay,
or,
okay. During the recovery phase.
Yes.
Yes, like every normal person that has undergone surgery, irrespective of his maybe cesarean section, there'll be no surgery. You will not want to put pressure on the abdomen, lifting up of heavy objects, bending to wash clothes and all that. At least for some timelines, maybe till you feel strong enough to do that, maybe 2-3 months at least.
Okay, there's another thing is, okay, I've had some persons who have gone through CS complain of severe back pain, waist pain, and it sometimes looks like it's a lifetime thing.
It's not a lifetime. It's a one-off, actually, because I've actually had patients that have said that some of them they want to link it up to the spinal anesthesia they had, that they feel that is what is still giving them, causing the backache and all that. But I don't know how possible it is, but from studies it's not supposed to. You're not supposed to. But in those patients, we usually advise physiotherapy, a physiotherapist review, and also undergoing physiotherapy will also help to ameliorate such symptoms.
Okay. All right. Well, this is still the program Inside Motherhood here on Spectrum Television. My name is Rachel David White, and I have in the house Dr. Ikomobongodo, and we're talking about cesarean section, a process where a woman puts to birth through surgical operation in order to bring out the baby. Now, we just have limited time. We're here to attend to your contributions, to your calls, send a text message, send a WhatsApp message, and of course, you can put a call across to us. All right, so Doctor, it seems we have gone through those major stuff that we needed to talk about. In just a second, let's see if we can take a call. Hello, welcome to the show. Good afternoon. Welcome to the show. Good afternoon. All right, so we lost that call. Put a call across to us. You can send a WhatsApp or a text message. We are here to attend to your questions. We have 4 minutes before we wrap up the show. So we are here to attend to your questions, your contributions, or your comments. We are talking about cesarean section. Have you been on that road before? Is there any question you would love to ask? Is there anything you would love to find out? Let us know. All right, so, well, some people are asking, why is it that if a baby is not in the right position, the hospital will not adjust it, but the traditional birth attendants will?
For real? Depending on the malposition, the right position for a baby is head down, and any other position aside that is all for malposition.
So is it possible for, okay, I've seen a process where, okay, I've seen a clip, not here, but outside Nigeria, where a doctor tried to turn the baby.
Yes, it's called external cephalic version.
Sometimes we hardly find that in our hospitals, rather the traditional birth attendants.
Most times, because probably they don't meet the criteria for that external cephalic version to be carried out. It also comes with its own risk as well. So you have to properly assess the patient and make sure she's actually qualifies for the external cephalic version to be done. And it's not just done anywhere. It has to be done in a facility where an emergency cesarean section can be done, the blood bank services, neonatal services, because anything that happens would require an urgent delivery.
Okay.
Yeah.
Okay, so what do you have to say to those people who are out there saying, no, my church says no, it has never happened in our family. Probably the woman is married to this man's family, and you hear, oh, this has never been our family history. I don't know where she brought this from. Or you hear things like, no, that is not my faith. My church doesn't permit it. You hear things like, she's not woman enough. You hear things like she didn't pray enough.
Yeah, we hear all sorts. We hear so many of those.
So sometimes you are in the midst of women and you hear some of them, especially in the rural areas, say, "Oh, she doesn't know how to push. She's not woman enough."
Not woman enough. Yeah. Why would you let them to cut you to bring out your baby? You should push. Those are the myths.
So you hear things like, "Oh, in our dialect, Abasikano Manikwa."
Yes. Those are wrong. They are wrong notions. Yes, vaginal birth is the safest.
Okay.
Yes, but there are times whereby vaginal birth cannot be possible. To no fault of the woman. It's not her fault. Vaginal birth just can't be possible because of certain criteria like the indications I mentioned. You won't want to attempt that just to prove a point that this woman has to deliver vaginally when her life and that of the baby is at stake. No, you won't want to try that, and that's why we have to urgently go in section and bring out the baby. It doesn't make the woman less of a woman, because subsequently, the next pregnancy, she can be lucky, get pregnant, and also have vaginal birth subsequently. So, vaginal birth, cesarean section is not the end of the world or end of vaginal birth. You say, okay, because she has been cut open to bring out the baby, then yes, that's what most people say, but with proper assessments after a previous cesarean section, you can as well have a vaginal birth after cesarean section.
Okay.
Yeah, just that going upwards, the increasing number of cesarean sections you have, the less likelihood of us here in our climes allowing for vaginal
Okay,
birth.
now that brings my last question for you. How many times would you advise a woman to, go through that path?
Go through cesarean section.
Yes.
That's a very tough question. You want to tell me to plan people's family for them?
No. But it's just
Oh.
okay. I hear people say 3 times is safer, but you can go up to 4 or 5.
Yeah,
So that's what I
yes,
expect
that's
from you.
that's what I was about saying. Yes, 3 cesarean section. The higher after the 3rd cesarean section, the more the cesarean section, the more complications that you will encounter when you go in for
I
the
hear
cesarean
things like you
section.
have to. The more you lose blood, the more you stay in the theater.
Yes, the more you have abnormal placentation, the more it becomes difficult to delineate those layers while trying to get to the uterus.
Okay, because you have to cut the same layer.
Yes, with subsequent cesarean section, they tend to be matted together. So during the cesarean section, while trying to identify each layer, cutting through those, you might inadvertently get to a structure that you might not want to, and then you injure those structures. So the higher the cesarean section, the more likely the complications that I mentioned about cesarean section, the more likely you are to have them. So 4, 5, very, very highly risky, actually.
Okay.
Yeah.
All right. Okay, so let's see, one last contribution before we end it now. Let's see, discrimination on women that has undergone CS. I know we've talked about that a little, but just a little thing to say to the people as your last advice for them.
Okay. I would say, please, we shouldn't discriminate women that have undergone cesarean section. Undergoing the cesarean section is no fault of theirs. There are obviously indications why that cesarean section was carried out. And it does not mean that because she has had a cesarean section before, especially if it is the first time, that subsequently she will have a cesarean section. What every mother wants, and also what every doctor wants, is to have a safe mother and also a safe baby. So we trying to achieve that in whatever way we can does not mean that we're making this woman to be less of a woman. So please, the public should abuse their minds from such notions.
All right. Thank you so much, Dr. Ekomobong.
Thank you very much.
All right. So back to the people. Now, this is me saying it from my heart that our churches, our mosque, our religious places, our mothers, our sisters, our environment, organizations to do well to avoid discriminating women who have gone through cesarean section, especially those ones that did not opt for it, but it just came. It's a process of bringing out a safe baby and, of course, a safe mother. We still have people who have gone through the normal vaginal birth but die along the line. Sure. Meanwhile, the people who went into the theater came out alive with that baby. So the thing is coming out alive, staying alive to nurture that baby and bringing out that baby you carried for 9 months alive. All right, meanwhile, my name is Rachel David White, and I had a lovely time talking to you today about cesarean section with Dr. Ekomobong Odo. All right, thank you so much. I'm sorry we couldn't take your calls. Network played a whole lot of pranks on us. But if you have questions and comments concerning cesarean section, feel free to send your messages to our number. The number is displayed on your screen. And of course, subsequently, we will address that issue. Thank you so much for being a part of this program. Don't forget to follow us on social media and subscribe to our YouTube channel, all of which you can find on our website, spectrumtv.ng. My name is Rachel David White. Good afternoon.